do is, we don't want to do another lecture through this way. This is a kind of tutoring session. And what we usually do is, one of you will have to come forward for each EEG. Come to here and then read it and tell us. Don't be concerned about mistakes because, for example, I think there's a saying that usually success is a lousy teacher, isn't it? But on the other hand, if you make mistakes, that will make you to learn more. So don't be bothered about it. We would have made more mistakes than what you're going to do when we learned EEG. So don't be, I think, boldly come forward, and that is how you learn the EEG. Let's see, we have to project it.
Yeah, project the computer here.
You take your time because EEG cannot be read quickly. If you hurry, you are likely to make the mistakes. For example, usually when you start reading the EEG, you will not be given any clinical data. Later on we'll tell you, then you may be biased. If the patient has got epilepsy, everything is standing there will be a spike, isn't it? Because you are already biased. So two things you should be given is, one is the age of the patient, because the EEG is influenced by the age. And number two, if there is a state of the patient, whether the patient has any kind type of coma or pathological altered sensorium, that one should know. But awake and sleep you should be able to make by reading the EEG. That's what we taught you through these two lectures. So this is written as an 11-year-old child. That's all. There's a first page of the EEG. So when you start reading the EEG, remember that the first lecture was on the technical aspect. So you should look at whether this EEG is technically satisfactory to be read. Because if it's technically very poor, then what the usual saying is garbage in is garbage out, isn't it? So if you are given a very badly done EEG and ask you to read, that's not appropriate. So whether technically it fulfills. So you should look at here, where all those filters and the amplitude and all are there at the bottom. And then you should look at the montage, isn't it? So that you should tell, and then start reading the EEG. Okay.
Should I start, sir?
Please.
Yeah.
Be louder so that everyone can hear. You can give your input later if you don't agree with what she's telling or what we are telling. So usually more is learned by asking questions, isn't it?
Yes.
Rather than listening to somebody.
Yes, sir. Okay, thank you, sir. This is a EEG of 11 years old adolescent, and it is in bipolar longitudinal montage.
Are you able to read that one?
Yes, sir, I can.
Okay, so tell that also.
And the paper speed is 30 mm per second. And the filter setting is minimum at 1 Hz and maximum at 70 Hz, which is appropriate.
So low frequency filter, high frequency filter.
Yes, sir.
Not minimum, maximum. Low frequency filter, high frequency.
And high frequency filter. And notch filter setting is at 50 Hz, which is ideal for Indian
So
settings.
notch filter is on.
On.
Okay, on or off. So let us just switch off and see what happens. See? So
Yes,
that's why notch filter is on. What has happened now? When I switched off notch filter, what happened?
Many artifacts have come.
What artifact?
Means outside artifact, electricity artifacts.
Yeah,
So this is
50 cycles artifact.
50.
So actually, ideally, notch filter to start with should be off, isn't it? Yeah.
Okay.
So then but most of the time, in the settings in which EEG is routinely done, there will be a lot of 50 cycles artifact.
Yes, sir.
So you switch it on, if required.
How to get rid of this? This is diffuse 50 Hz. If it is in one electrode, 50 Hz, that is the electrode problem.
Okay.
The impedance of that electrode is very high, so you have to reapply and take it out and do skin preparation properly. But here it's diffuse everywhere.
Sir.
So how to rectify this? how to rectify 50 hertz artifact like this.
Just to on the notch filter.
No, that we will do.
That's a
Beyond that.
awning the, see, you should, Dr. Attu told you, no, ideally one should use the filter very carefully. So usually there is a saying that you use the filter of your brain and don't use the filter of the machine.
Okay.
So what Lakshmi is asking is, how do you use your brain and filter and try to avoid using
Switching
the
on
machine filter?
Yeah. Switching on the notch filter should be avoided as far as possible.
Every
so
kind of
best
filter.
way to avoid this is to have a good grounding earth.
Yeah.
Earthing of your EEG lab, good ground earthing. Like there's a separate earthing should be done to the electrical port. So that is the best way to avoid this. So once it is recorded like this, there is no other way. You have to only switch on the notch.
Right.
Settings.
That's something like a whitewashing, isn't it? It is there, but then you have whitewashed it. But fortunately, the information is not lost most of the time, but it can be lost to some extent. So if you want to avoid that, have a EEG lab which is properly electrically protected, what you call shielded, and earthed. Then it will not occur. That of course should be taken care of when the position where the EEG lab is positioned, wiring and all these kind of things should be taken care of. Most of the time this may not be possible. No, you bring up the EEG lab in whichever place is available,
Yes,
not
sir.
away from the electrical source, like your lift or elevator may be there in the neighborhood. That will all generate the electricity. So
Sometimes that electrical box have multiple plug holes, right? So some other devices may be plugged in the same.
In the
Say
same.
for example, common error is the bed which has electricity that is plugged to the same port. So you remove all that, this will go away. First is the earthing. Second is you just see in that whole box only the EEG amplifier is connected, nothing other electrical appliances are connected. So that is one way to remove this.
Okay, sir.
And now people charge mobile phone in the and keep it on the bed.
Mobile
Those
phone.
will cause this. So
Okay.
those are simple troubleshooting.
All the devices will cause it. So more often you have to use the 50 hertz, the notch filter will have to be on. But ideal thing is to keep it off and then try slowly and steadily improve the setup of the EEG lab in various ways. Okay. Now start reading. And then the montage,
It is bipolar longitudinal.
bipolar longitudinal montage. And you should also describe that the left and the right.
Yes, sir.
And the two lower ones are for the central region.
Yes, sir.
And also tell that there is one channel for the ECG. Otherwise, you will forget that.
Okay.
So after by noting that, you know that okay, I have to see the ECG also, not the EEG alone,
Okay.
because patient may have some syncope or something like that, and what is important is the ECG there. Okay. Now after having that much information, then only you should look at then the first step is to
See the background.
define the background activity, which is defined from posterior to anterior,
Yes, sir.
and then compared between the two sides.
Correct.
Okay.
Okay.
So that is the way it
Okay.
should go.
So odds figures are for left side and even figures for right side. The first is on the left side, parasagittal region, and the background frequency.
So you call it a frondo central chain,
Yes, sir.
isn't it? Left and right, then temporal chain, left and right,
Okay.
and central chain.
Okay.
And then one for the ECG or EKG, whichever term you want to use. Okay, now start reading it.
There is some graduation means in the amplitude from posterior to anterior, gradient I should say.
No,
That-
posteriorly, your job is 11-year-old means the child is likely to have alpha activity, isn't it? Above 8.
Yes, sir.
So majority of the posterior activity should be alpha.
Alpha.
So define the alpha. Initially you start the frequency, then you say the amplitude, then symmetry or asymmetry, anything significant asymmetry, symmetry, and then you are going to look at any additional waveforms along with the alpha in the posterior head region. Then you look at the responsiveness of the alpha. Then you go to the central region and the anterior head region, isn't it? That's
Okay.
how you use. Okay.
Okay.
If you're systematic, then you will not miss it.
Okay.
More often we bypass these things and then end up in problem later. So start from the posterior.
The frequency is 1, 2, 3, 4, 5, 6, 7, 8, 9. It is 10 about.
Yeah, 9. And remember that alpha will not vary for more than 0.5, 0.5.
Oh,
So you should not say 9 to 10 alpha. There is nothing like that. So either it is 9 or 10. So any difference between the two sides of 0.5 is abnormal. And any amplitude asymmetry of more than 50% is abnormal, whether it is technically abnormal or physiologically abnormal, that's differentiated. But here it is, you are right, that 9 hertz, it is more or less symmetrical
yes, sir.
in amplitude, isn't it?
Yes, sir.
And okay, now thirdly, before this is moved to check for the responsiveness, and are there any additional waveforms? Okay, immediately you should say 11 years. So what are you looking forward to?
Youth.
Posterior slow waves of the youth, isn't it? That's commonly present at this age.
Can
So
you
it-
point out where do you see
On
posterior
the-
slow waves? Can you point out with the pointer?
In the occipital, like posterior head region, we used to see.
No, where is it here?
Here,
Point-
can you show to the others that
A
where
little
are the
bit.
posterior slow waves of the youth?
Okay, better example. Yeah, what you're showing is there. Better example.
This one, this.
What
Let-
about
Yes.
that one fulfills all the criteria. So it is, the dome is there, alpha is overriding over the dome, and the amplitude is not more than rest of it, isn't it?
Yes, sir.
So, and that is also seen on the other side. So otherwise you might confuse it as a intermixed slow activity over the posterior head region. So it's coming in an adult. This could be abnormal. So for a
Okay.
child of this age,
It should
this
be
is
normal.
normal,
Okay.
isn't it? So that's how it's important. So there are the slow waves of the youth. So you saw both the alpha as well as the slow waves of the youth. And here you can see that this alpha waxes and wanes in amplitude.
Yes, sir.
That some people call it a spindling effect, and some people have tried to correlate it with the respiratory cycle.
Oh,
But that's not abnormal. That's a normal alpha. It is not seen in everyone for reasons which are uncertain, isn't it? Okay, what about the waves elsewhere? Now, posteriorly, you go slightly anteriorly. Central region, you would like to look for. So what is a normal central rhythm, which can sometimes be confusing,
it is beta.
which can be misinterpreted? Mu rhythm. Mu rhythm occurs over the central region, more frequent in children. But here there is nothing significant, isn't it? The central region showing some degree of theta, but it is okay. And anteriorly, frontally,
It is little bit amplitude
Faster.
is less and fast.
faster. So frontocentral region usually will show a fast activity, which can occur normally, but is usually aggravated or increased by the sedative medication.
Okay.
I mean, patient. So that's what you see now. Anything else you want to describe in this space? So you have seen a normal range alpha activity for the age, symmetrically distributed, intermixed with slow waves of the youth, some theta activity over the central region, and beta over the anterior head region, isn't it? So, okay. Now what you want to see next? The most important quality of this alpha is responsiveness to eye opening, isn't it? That should be then only you can say that this
It
is
is
an alpha
normal.
activity, because that's a criteria. The most important criteria is responsiveness to the
Eye
eye opening.
opening.
Okay, let's see that.
So we'll go to the next page. At this page, there is no eye opening. So next page. This is just the next page. Here again, the alpha is continuously there.
And here, one thing which you have to see is that, for example, concentrate on this particular region. The alpha activities, there's one alpha wave is quite prominent, or in inexperience you may say that it is quite sharp. And there is a posterior slow waves of the youth have come after that, isn't it?
Yes, sir.
There's a common misinterpretation which is made, is that it's a spike and wave.
Yes, sir.
Can't blame them till. But then later on, you will see that there are other criteria to say that it is spike. Many other criteria should be fulfilled. We are not going to go to that. For example, see this. In EEG, there is a saying that when I ask you to see a particular region, you see that only. Rest of the EEG is not seen to you. And usually you say that, no, that Panjali Swayamvaram, when Arjun was
Yes, sir.
asked about, he saw only the eyes of that eye of the bird. So you utilize that eye of the bird here. You will, suppose you say that there is a spike and wave. To beginner, it's quite okay. That's what it is. But then it doesn't fulfill the spike criteria, which you're going to learn in the subsequent lecture. What is that and all, why it's not. It's okay.
So we have something here in the middle of the page.
That we might keep it for, because artifacts is not discussed. Isn't it? Eye blinks and all. So we'll.
The responsiveness also not that great.
Yeah.
Alpha block
But
also
this
not
is
that
actually, child is blinking.
Yeah.
Have they tested it properly?
Properly or eyes open.
For example, later on, go back into that. What is happening there is that the child is blinking. That you'll be in, there's a session on artifact. In that, they will teach you that how you recognize it as a blink artifact. We don't want to go there. But for the IO, this will not really test the alpha reactivity, because child is blinking, opening and closing the eyes.
Okay.
There it has to be kept open for at least 5 seconds and then made to close. Then only you'll be able to. Let us see whether it has been tested properly or not.
Not that much.
That's if there is any technologist who is attending this, it's important to do that a few times in the beginning of the recording, at least for the eye opening, wait for 5 seconds, close it, and then see that the alpha has come back, and then making it do it 2-3 times. Otherwise, you will not be able to recognize that. Okay.
There is a brief eye opening here for 2
Yeah.
seconds, but again, lot of artifacts.
Lot of artifacts.
Gets blocked here 2 seconds. You can see.
For example, similar activity in the alpha range can also come in alpha coma, isn't it? So what are the differences there, the alpha?
There will be no attenuation of alpha.
Before that, it has got a difference in the distribution. Instead of posteriorly, it will be more seen over the central or anterior.
Okay.
And it will not be responsive to eye opening. And it will not also fluctuate like this in amplitude.
Okay.
So it's a kind of monomorphic, or what you call monotonous alpha. In the beginning till end, it will be the same, more central or anteriorly distributed, and then unresponsive to eye opening. So that's why you are looking for all these things in the, okay. And you are seeing a lot of slow waves of the youth. And this is the, in between, you are seeing some background fluctuation, especially over the right posterior head region, isn't it? Below this particular region, isn't it? This again, these fluctuations are very common. In fact, one study from US concluded that the commonest cause of misinterpretation are the normal background fluctuation. For an inexperienced, that region will be considered as multiple spikes or multiple sharp waves and all. But remember that is normal. Why it is normal is it does not disturb the background activity. So later on they will tell you that the most important, just like the eye opening, responsiveness is the most important prerequisite of an alpha activity. The most important attribute, characteristic of a spike is that it will disturb the ongoing activity. So if it is merging with the ongoing background activity, it cannot be an epileptogenic spike or a sharp wave. Without that, you should not diagnose it. All these we are emphasizing because later on you will learn that these are the commonest mistakes made in reading the EEG. So that background fluctuation is normal. It occurs in some people more, some people less. That may be related to mental activity and other kind of things. We really don't know. But the most important thing is these background fluctuations are common. And that's a common source of error in reading the EEG. One of the common source of error.
And there are some alpha dropout also for 3-4 seconds.
Yeah.
Patient is a little bit drowsy.
A little bit drowsy in between. Okay. Okay, now what is happening? In this page you read. Now you have seen the alpha activity, you have defined the background activity for a particular patient. And most of these are, for example, suppose you happen to see these patients with multiple EEG, some kind of pattern is very typical for that individual, isn't it? The alpha frequency, that won't change, and the responsiveness. The slow waves would disappear with age, but rest of it will be the same. So here what is happening now in this page? Now you should have a mental picture of that one to the initial pages you saw. So you already know the background activity. So anything which is different from that is called a transient, isn't it? Which need not always be sharp. If it's sharp, you call it a sharp transient. If it is slow wave, you call it a slow wave transient. If it's fast activity, it could be a fast wave transient, isn't it? Okay. So transiently something different from the background is happening. That's the definition. Okay, here, what's happening there?
So what are the changes? This page and the first page. Anyone?
Slow transient.
Your mind now should compare between what you saw initially and what you are seeing now. Number one, will you say that alpha is dropping out? You are not seeing it continuously as before? Okay. Number two, will you say that the fast activity has become more frequent, beta activity?
Yes, and in the frontal.
That was the second difference which has occurred. And we also see that after the alpha is not seen posteriorly, when it came in this region, it has got a higher amplitude. Agreed or no?
Yes, sir.
Okay. So that means this patient is now going into alpha dropout is usually the first sign of drowsiness. And the technicians should recognize that. Otherwise, if the patient is drowsy, and at that time she goes and asks him about 100-7 test or something, that sleep is abolished now. No, patient may not be able to go to sleep after that. That is why they should be careful at each step of doing the EEG, isn't it? So the patient is becoming drowsy, and during drowsiness, the beta activity becomes more frequent. So that is what is happening. And what do you see that prominent alpha activity which stood up? That's a paradoxical alpha. So if you don't understand that, you will say that, okay, some sharp waves are coming over the posterior head region. But that again does not fulfill the criteria for any epileptiform abnormality. Okay.
Central theta.
Yeah, some theta activity has come over the central. So the central theta increases and the anterior beta increases and the posterior alpha diminishes. That's what happens. That's how you recognize the drowsiness. What else will happen during drowsiness? The blink artifacts will go away and slow eye movements will appear over the anterior head region. So let's go look at that. Now the alpha is becoming less and less and the beta theta is becoming more, then the paradoxical alpha has come because patient is just alerted, some disturbance, somebody would have walked into the EEG room or someone was talking outside. EEG lab is supposed to be quiet, but more often it doesn't happen in a hospital setting. So that has brought back the alpha in a better frequency. And how do you know that the patient is alerted other than blink artifacts have come? Myogenic artifacts have also come. So the patient is, so when you carefully look at the patient, just like a running commentary, you should be able to tell, okay, this patient is sleeping now, somebody has disturbed the sleep, and he is waking up, all those kind of things, So that is how the EEG, if you read like that carefully, then, of course, I always tell, so you have told about mostly about EEG, but don't forget about the ECG also, isn't it? That is coming at a regular rate, isn't it? And the frequency is also within normal. You should look at the rate and the regularity. That's what.
So all of you appreciate the difference between the first half and second half this page. So first half is patient is very drowsy, where there is no muscle artifact. There's a lot of frontocentral beta is there. But second half, when the patient is more alerted, someone is trying to do the eye opening, eye closure, and asking the patient to hyperventilate. So you have a lot of frontalis muscle artifact, and the beta is gone. Look at this page here. The frontocentral beta is not that much prominent here, and very good alpha has come back, right? So these are the changes. More alerted now, more awake. So he was about to fall asleep, but inadvertently the technician woke him up, right?
And tell me the heart rate now. No, in this patient. How do you calculate the heart rate from the EEG? You know that cardiac arrhythmias are better detected in the EEG lab by the neurologist than by the cardiologist in the ECG lab.
Yes,
sir. We are more often tell them that this patient has arrhythmia, requires further cardiac evaluation. So you should know how to derive the heart rate from the ECG.
70?
Anybody?
Yeah, someone says 75.
75. How did you come to the 75? The RR interval. The quickest way is that 1, 2, 3, 4, 5. 5 seconds, isn't it? So 5 seconds, how many QRS complexes have come?
6.
6.
6 into 12.
So 6 into 12 is 72.
72, almost 75.
Because you have counted it for 5 seconds. So 1 minute is 5 into 12, isn't it? So how many has come and, okay, and there is it very regular or, for example, here there is a wider RR interval. Here there is a shorter RR interval. What is happening there? Alerting, no. It can occur even without, so that's a sinus arrhythmia.
With respiration.
So that also can be seen in that's why I told, EEG will teach you more about the cardiac rhythm also to detect, let's say normal, that usually happen in youngsters more, isn't it? 11-year-old child. And you might also say that since it is prominently seen, this boy may be athletic also. This more occurs in people who are active and athletic, isn't it? Sinus arrhythmia. Okay.
So going forward, so patient is now fully waken up. So the technician is not allowing the patient to sleep, right? And hyperventilation is started. So at this point in hyperventilation, what do you want to see? In hyperventilation, we know it's an 11-year-old child. What do you want to see?
slowing should come. A normal response to hyperventilation, subtle slowing will come in the background.
As I told you, the hyperventilation is something, all these procedures, whatever you do in EEG lab should be technically acceptable, isn't it? So one is that child should be explained about the particular thing. And ideally, hyperventilation is done in the sitting position.
It
Then lying down
reclining and
position.
sitting position.
And you should be told that you should bring up a rate of 20 or more,
Yes, sir, for 3 minutes.
provided
minimum.
is cooperative, and continue it till for 3 minutes till the technician tells to stop. Or if you feel something uncomfortable, he can stop in between, isn't it? If it's
Yes.
so, and then one has to watch the patient also, whether anything happens into. If he starts if he got an absence or start blinking and getting a stiffening, immediately stop it, because it's not allowed to continue, so that the room should be lighted, isn't it? Unlike in the photic stimulation, you make it, you dim the light. But here, if you do that and don't observe the patient, he might get a seizure and fall down or something like that. All these are important and during hyperventilation. The rate is very important, and the achieving the rate and all. Okay.
Compare this page and your first page. So what are the changes compared to this page and your first page? Question is understandable? Okay.
Yes, sir.
This page, compare with your photogenic memory of the first page, right? What are the changes you are seeing in comparison?
The amplitude of the background wave, it is getting increased.
Yes?
Yeah.
Yeah? They are
Good.
higher
That's
amplitude.
good.
Yes?
And slowing is subtle slowing, not much.
Yeah?
Yeah, there is slight slowing.
Theta
For
slowing is
example,
there,
if you look at this region, some of the activity, the alpha frequency has come down, isn't it? And I told you that normal physiological alpha will not change more than 0.5.
Oh,
So even change of 1 is important.
Yes,
That
sir.
tells you that a different rhythm is building up. Okay.
What else?
and that frontal beta is going lost, means that in normal there was beta wave in the frontal leads, that is not much here.
Yeah, now
But-
the patient is more alert. So
Alert.
he is doing hyperventilation, so the frontal beta is less prominent compared to the drowsy. Okay. But compared to the first page, there are more changes. See this theta activity in the frontocentral theta. So that was never there in the first page.
Okay.
Okay, so first page was the last two channels were alpha, the first two channels were beta. That was how the first page was when the patient was very relaxed, eyes closed with the awake state, right? Now he is more alert and hyperventilating. And you have a lot of theta here. Are you able to appreciate the theta in the frontocentral region?
Yes, sir.
So this is the main change, apart from increase in amplitude and decrease in the beta activity. So what else you expect? For 11-year-old, what else you expect? So this is generalized theta activity has come, little bit more frontocentrally. Okay. What else you expect? Say for example, this patient is a case of childhood absence epilepsy. On treatment, you want to assess treatment is adequate or not. You want to assess whether we can come off the medication or not. Correct? So for that, one important question should be answered. Hyperventilation, whether the child has done properly, adequate effort, adequate changes have happened. Many times they ask the patient to hyperventilate, they put the green bar, but the patient actually not hyperventilated that much.
That's it.
So the hyperventilation changes in the EEG, you should be satisfied. Okay, the patient has done hyperventilation properly. Then only you can say, okay, absences are not coming now. Maybe the patient is in full complete remission electroclinically. We might reduce the medication. Are you with me?
The
So effectiveness of the
technician should note down, okay, rate this much should be more than 20 and deep and rapid. I mean, how much rate means 20 to 25. Beyond that it would be difficult to do. And more often done in sitting position in the early part of the recording. So usually do the hyperventilation at the beginning and photic stimulation at the end. I mean, because that photic stimulation is an alerting response, isn't it? Okay.
See this frontocentral theta very nicely here. All of you are able to appreciate the frontocentral theta 6-7 hertz here at the end of this page. Okay, so this is the hyperventilation response. In some younger children, you will have a very prominent rhythmic delta activity. 3 hertz, 3.5 hertz rhythmic delta activity in a more younger child, 5 years, 8 years, like that. So We need to assess the effectiveness of hyperventilation on EEG also by looking at slowing is, if the grain bar is there, hyperventilation is there, but no slowing at all, no theta is there, you know, like hyperventilation was not done properly.
What is abnormal during hyperventilation? This one, when do you call that hyperventilation response is abnormal? Suppose there is, sorry?
So asymmetric slowing.
One is that, hyperventilation response, as I mentioned to you, is highly variable. Many of the adults, there may not be anything at all, in spite of him being vigorously ventilating. That's not abnormal. To say it abnormal, one is that whatever slow activity is coming should be persistently asymmetric. Occasionally, especially in children, it may come more on one side than the other side. Overall, it is equal. You don't attach any importance to that.
Especially frontal intermittent rhythmic delta, FIRDA. Sometimes it can come asymmetrically right, left. That is not abnormal.
That's not.
But if it is persistently focal slowing, only right temporal is slow during hyperventilation. Persistent focal asymmetry, that is always abnormal.
And second is when there is spike and wave discharges are brought out, whether it is focal or generalized, that's abnormality. Thirdly, previously it used to be taken that at the end of hyperventilation, 3 minutes, it's over.
Yes, sir.
At the end of hyperventilation, the technician should observe the patient for the next 3 minutes, how the hyperventilation response is going away. That again is highly variable. When we were all started the EEG, people used to say that beyond, if it is lasting for more than 3 minutes, it was considered as abnormal. And there was a time in which that was more common to be associated with Moya disease and all those kind of things. But those are no longer. In fact, in Moya, one should not make the child to hyperventilate at all, sickle cell anemia and all those things. So the persistence of the hyperventilation induced slowing beyond 3 minutes or 5 minutes is not abnormal. That's not usually taken as abnormal. And many a time, especially if you make the young child to blow against the windmill or something like that, I mean, it may be difficult to make him stop it because he has enjoyed it. So the technician not looking at it, they won't even know. They will say, they will mark it as when she told the child to stop. The child may be still doing it. So because of all these reasons, you don't consider it as abnormal. So two things are, one is asymmetric slowing, persistent asymmetric slowing, and number two is epileptiform. Epileptiform waveforms are precipitated. What that means, you will know later. What do you mean by the epileptiform waveform? Okay.
So sometimes what happens, very high amplitude rhythmic delta, diffusely coming, but no spikes at all. 3 Hz, 3.5 Hz, rhythmic, generalized, diffuse delta activity, slowing is coming up during hyperventilation, especially in a young child, but no spike wave. So this is not abnormal.
Is there an example?
This is normal.
Sometimes, as you heard it, during that exaggerated hyperventilation response, is there anything?
Not in this patient, sir. Yeah.
Next patient or something. Because there also you have to be careful, because when you make the child hyperventilate for 3 minutes and you ask him, how are you doing? He will say, I'm feeling giddy and I'm feeling a bit sleepy and all. And many a time you may say that, okay, silentness is not as good as before. And along with that, the EEG is showing a high rhythmic delta activity. And there, sometimes what happens is that the ongoing background activity, coming in between the delta activity, you may, just like the slow waves of the youth, you may make it a spike and wave. All these things put together, you may make a wrong diagnosis of absence. That's what you call pseudo-absence. So there you have to, because how much amount of lack of awareness should be there for you to diagnose absentia? It should be a dense clouding of the sensorium, that the patient should not be responsive or there should be an interruption of the activity. Child says that I am not feeling as good as before. This all should not be taken up as this. Maybe in the afternoon session, Lakshmi will show you that how to test for responsiveness during hyperventilation. that we are not doing that because we are discussing the normal EEG.
This one, alpha variants.
Yeah, that's okay. They have seen in people. What would that you can show them that you want to show the.
Yeah, what is happening here? This is some other patient. Okay, what is happening here? So this is a regular alpha. Suddenly something happens here. So count this alpha here. 1, 2, 3, 4, 5, 6, 7, 8, 9. Exactly 9. 9, 9.2 like that. And count here. 1, 2, 3, 4, 4.5. Yeah. So this is called? No. This is called?
Slow alpha
variant. Harmonic.
Another clue to that is, if you carefully look at some of the waveforms have got a bifid appearance.
Notched.
Isn't it? Notched actually. That bifid tell you that it is trying to fusion, trying to merge together. So that is the other clue to say that it's a slow alpha variant.
So this should not be reported as occipital slowing or occipital spike wave. That is the main importance. So why we are emphasizing so much here, all these normal variants should not be reported as abnormal, right? So this should be identified positively as this is a normal variant. Here you have another page where it is an initial 2 seconds, very nice alpha.
Here is, you can see that bifid pattern, isn't it? 2 waveforms for the dome of it, isn't it? That is trying to merge.
And there is some asymmetry also. The slow alpha variant is bit more prominent on the right side than left side. So all the more it will make you think that it may be abnormal thing because it is only one side, right? So all these caveats we should know before we report this as normal or abnormal. So normal variants are the ones we should be very, very, very thoroughly aware of before we call everything as abnormal.
Otherwise, this is what you call overreading of the EEG. Overreading of the EEG
this
usually
page,
brings up.
Very, very asymmetric.
Yeah,
Sir.
that is.
Very asymmetric, only on the right side.
Right. Okay, you can go. I think you saw most of one is recognize alpha activity, its distribution you saw, then you saw slow alpha variant, you saw the only thing which you did not see well is eye opening response was not tested properly, and mental arithmetic also is not tested up till now. So you want to show you want to show in another EEG the eye closer response, possibly not properly tested, and
I think mostly it's asleep. It's mostly sleep.
that child is drowsy from the beginning. Sleep has come. But we show sleep
Yes.
also. Okay. Is there a alpha from the beginning, and then we'll
I
tell
think
them
it's
that
not very
starts with a.
awake, but it's not that very well defined alpha.
Okay.
So responsiveness is difficult. It's there, but low.
That's a mu. Just show that this mu which is coming. Okay. We increase the amplitude a bit.
It's all-
What is that rhythm which Lakshmi is trying to show you? Forget about the rest of the EEG. Now you should be comparing between the two sides. So one is to describe the waveform frequency. What is the frequency? It's almost similar to the posterior alpha, isn't it?
10.5.
Yeah. And but that central region look a bit more sharper than the alpha. You agree? Okay. Then it is more seen over the central region, and in fact it is reversing there.
C4.
You know the phase reversal which Dr. Athod showed you. So it is reversing at C4. So it's a central rhythm. It has occurred asymmetrically. It is coming on the right side. So that's a mu rhythm. In the central region, frequency similar to alpha, sharper, occurs over the central region, and the rest of the alpha is not seen. And I told you mu can persist during the early stage of drowsiness. It also persists during eye opening. That is why it is misinterpreted as abnormal, isn't it? In the So, but that is the mu rhythm, and what the technician should do at that time, how to confirm. It should be responsive to motor activity. It will not be responsive to mental arithmetic also. Motor activity, so that it is seen on the right side. Technician should ask the child to do what you call wiggling of the thumb. That's or make a fist like that. That should be done in which hand?
Left hand.
Left hand. Usually contralateral. Sometimes it can occur ipsilateral also. So that is the tech should observe the child during that thing and then make it do it. So that's a mu rhythm. So you have seen that also. Then,
Some alpha is coming up.
yeah, that you can see the mu rhythm on the other side now.
Here.
So it alternates between the two sides. And some of those, you see that some of those waveforms are a bit sharp, isn't it? If you are inexperienced, you'll say that there is a central spike and all this. But it's not a spike because it did not disturb the background activity.
Very good example, sir.
Yeah. It's
This is the best example for the
classical mu rhythm.
more prominent in the left side.
Mu rhythm.
This is another one.
Yeah. So what we are showing is another
Best.
is normal rhythm and some of the transients which can be confused as abnormal, but they are not abnormal. How to say that this is a normal variation and
So there is fast alpha variant also, sir.
yes,
Here
it
and
is.
there.
That's another mu. That's now you see that the posterior region, along with the alpha, some faster activity is coming. That's a fast alpha variant. Usually in the harmonics, 9. If the alpha is 9, this will come as 18.
8, 9, 10, 11. So the alpha here you can easily count, it's 11, but here you can see it's more than 20, right? So here. So immediately after eye closure, initially for 3-4 seconds it was much faster, then it settled down to his usual alpha. So this is a fast alpha variant. Earlier we showed you slow alpha variant. This is fast alpha variant. And you have to be careful, like sometimes the eye closure sensitivity, like Gibbon syndrome, that also has a faster activity, occipital predominant faster activity, but that will have a more spike. Here it's only fast but no spike. This is the main difference between eye closure sensitivity of Gibbon's and fast alpha variant. So this is again a mu bilateral.
Eye-opening response is...
Now it's more drowsy, bilateral theta. See, bilateral central theta coming in.
It will show some of the markers of sleep. Now they have done photic stimulation.
Yeah. So he was falling asleep and suddenly someone
Photic stimulation, that should be, it should not have been done. That's why
Very nice
one should
driving is there,
carefully.
sir.
Yeah, here you see that it is coming, let's just go back into, the stimulation is being done at 8 Hertz, and you see that the activity over the posterior head region driven by that, but a faster frequency. So that can also in harmonics, it can, for example, instead of 8, it may go to 16. It can again be harmonics.
So this is photic driving.
Right, okay.
So usually it can be 8, 16 or 24 like that. This is faster harmonic of that. And usually if the driving is there, it will be there in subsequent frequencies also, flashes also. It will not be only in 8. So it will be in 8, 10, 12, 14 like that. All the phenomena, photic phenomena will be there. Even in photoparoxysmal response, it will persist. If it is there in 10, it will be there in 12 and 14 also. So it will not come in only one flash and go off. So that's one way to persistence and reproducibility. You do it another time, it will come in the same frequency. So all these we need to check. Yes, prominent photic.
Go to sleep, 10 minutes only, they don't know, so some sleep markers. Okay, here it is. Okay.
So maybe
Go further, because it's okay, this particular page. Okay.
Yes. So what do you see in this page? Maybe someone else, maybe another volunteer, please. Another volunteer, please.
You're doing a good job. And
we will show
you some of the waveforms. I'll show you some waveform. You tell name it. This one.
What is that?
Because we are supposed to finish within 10 minutes. Anyone?
Yeah, lambda versus post. Which one is this?
It is in 32 years it should be post.
No. It's not about the age. It's the state of the patient.
Because-
Whether patient is awake or asleep.
It is sleep because vertex waves are
Exactly.
That is correct.
So lambda will not persist in stage 2 sleep. So this is post. This is not lambda.
It's called POS actually, POSTS. That's not for the singular and plural. That last S stands for the sleep. Positive, occipital sharp transients of sleep. So those are the posts,
These are
and you
very
can see
prominent,
that
very
very
sharp
sharp actually.
Easily someone can mistake
So
this
why
for-
it is not a spike? Why it's not an occipital spike?
disturbing the background. Background is
But if I want to question you, you say that there is some activity has come after that, isn't it? But that
Okay,
may
other criteria.
that may be sleep related, but there is a slow activity which has come after that. Polarity, what is the polarity of that?
Whether it's a
Why it is called positive? Positive occipital. So it should conform to that. Occipital should be positive. Is it positive or no? That's how we check whether you have understood the lecture Dr. Rathod has given you. Why it is positive. So again, just like that Panjali Swayamvaram, P4O2, you are not seeing any other channel there. Concentrate only on that and then tell me the polarity of that. O2 is positive or P4 is negative or vice versa?
P4 is positive and O2 is
Other way around. What Rathod told you is that negative to positive is up. Positive to negative is down. So here the P4 should be negative and O2 should be positive. That's why it's going up. So that's why it's not on the other hand, if it were a spike, later on we'll tell you that most of the epileptogenic spike will be surface negative and not positive. That are very rarely. So that is, on the other hand, anything which is positive surface-wise is more a physiological transient than a pathological transient. That's the rule usually.
So one important thing to realize here is, see in the third channel, nothing much is happening. All these sharp transients are in the fourth channel only. All of you agree? Fourth channel only is showing the prominent sharp transients, right? So that means it is end of chain phenomena. If it is parietal negative, P4 negative, it should be there in third channel and fourth channel and phase reverse. That is not happening here. It is only in the fourth channel. That means end of chain. End of chain means the activity is maximal at O2, not P4. So what O2 is a second input. What in second input will cause upward deflection? Positive in second input will cause upward deflection. So this is how you have to work this out. This is very important phenomenon to understand.
So
That's why it is post.
well done.
So we are waiting for another group, just another 2 minutes, then we'll start the next session.